To begin with the introduction, neuroendocrine tumors are typically located in sites like lungs and gastroenteropancreatic sites. In gynec oncology, cervix is the most common and primary area where neuroendocrine tumors are found. In neuroendocrine carcinomas of cervix is a rare and very aggressive entity. The incidence is around 1.4% of all invasive cervical cancers. This was first described by Alboris Saavedra in 1972. The neuroendocrine tumors originates from embryonic neuroectoderm and share the similar IHC stains. The median age of neuroendocrine cervical cancers is 27 years, and the range is from 27 to 77 years. Now comes the grading of neuroendocrine tumors. It is divided into well-differentiated neuroendocrine tumors and poorly differentiated on the basis of mitotic index and Ki-67 index. Grade 1 is also known as typical carcinoid. Grade 2 is atypical carcinoid. We see that grade 3 and poorly differentiated NENs, in both the cases, mitotic index and Ki-67 is more than 20. So the differentiating features are on histology. In histology of small cell and large cell, we get the small cell types, and so is the classification. In 2014, WHO gave classification on neuroendocrine cervical carcinomas, and they divided them into low-grade neuroendocrine tumors and high-grade neuroendocrine tumors. Low-grade comprise of carcinoid and atypical carcinoid, and high-grade is small cell carcinoma and large cell carcinomas. They also had one type of glandular tumors and precursor, where the histology was adenocarcinoma mixed with neuroendocrine carcinoma. The most common histology is of small cell carcinoma, where it is seen in 80% of the cases. It is followed by large cell carcinomas that is seen in 12% of the cases. Whereas the typical and atypical carcinoids are very rare in cases of neuroendocrine carcinomas of cervix. Now the biology and clinical presentation. At the time of diagnosis only, the tumor is known to involve lymphovascular spaces. It involves the regional lymph node basins, and at the time of diagnosis, it involves extrapelvic sites and is known to have local and distant relapses. The clinical presentation, patients comes to us with bleeding PV and watery discharge per vaginum like any other cervical cancers. On a thorough clinical examination on a biopsy, the diagnosis is a histological surprise. Small cell neuroendocrine cancers of cervix sometimes presents with ectopic hormone production. There are two cases where endocrine paraneoplastic syndromes have been reported. There was one report where the women having postmenopausal bleeding presented with intractable seizures and hyponatremia, persistent hyponatremia. It was because of paraneoplastic SIADH syndrome. Another case report was on a patient with postmenopausal bleeding with hypertension, diabetes mellitus, and persistent hyperkalemia. And it was found, after evaluation, it was found to be because of ectopic ACTH production and a Cushing syndrome. So rarely these can present with these paraneoplastic syndromes. The pathogenesis, like squamous cell carcinomas, neuroendocrine cervical cancers also share HPV infection as a cause. We have seen that in 86% of the cases, HPV association is there. Of them, 98% have single HPV DNA type. The most predominant ones are HPV 16 and 18. HPV 16 is found in 54% cases and 18 in 40% of the cases. Here we see that HPV 18 is 4 times more prevalent than seen in squamous cell carcinoma. HPV 18 because has more predilection for neuroendocrine and glandular cells. And this also explains the in the early nodal involvement and metastasis to nodes, lymph nodes in cases of neuroendocrine tumors. There has also been overexpression of P16INK4. Other oncogenic driving mutations found in neuroendocrine cancers of cervix are P53, KRAS, PIK3CA, c-MYC genes. Loss of heterozygosity has been seen. Deletions in chromosomal region 3p and allelic cross of chromosome and the region of 9p21 has also been seen. Then the differential diagnosis we think of is a small cell variant of squamous cell carcinoma, basaloid squamous cell carcinoma, and metastatic neuroendocrine tumors from other sites to the cervix, like that from lungs and gastroenteric and pancreatic regions. And then local spread from of neuroendocrine tumors from urinary bladder, rectum, and Merkel cell carcinoma of the skin, lymphoma, embryonal rhabdomyosarcoma, and undifferentiated carcinomas, because they all have on histology they have small cell appearances. So to conclude, get to the diagnosis, we use IHCs. In neuroendocrine carcinomas, the IHCs are neuron-specific enolase, chromogranin, synaptophysin, CD56, and while others that we can get is P16, keratin, and keratin. To differentiate it from the other differentials, in small cell squamous cell carcinoma, the IHC stains that are positive is P16, P63, keratin, and pan-cytokeratin, cytokeratin 5 and 6. In lymphoma, we see CD45, CD3, and CD20. In rhabdomyosarcoma, we get desmin and myogenin. In undifferentiated carcinomas, we can get cytokeratins and these IHC markers. Now, neuron-specific enolase is not only seen on the tumor cells of neuroendocrine cancers, but they are also present in the serum of majority of the patients. The the upper cutoff level of neuron-specific enolase in serum is from 16.5 to 20 nanogram per ml. This can be used in the follow-up of the patients also. And there is another novel IHC marker, that is insulinoma associated protein. It is very useful and specific in high-grade neuroendocrine cervical cancers. There is a study where it has been found that insulinoma associated protein was present in 95% of the cases, whereas chromogranin A and synaptophysin was found in 85% of the cases in high-grade neuroendocrine cervix. There is a study that was done to evaluate the HER2/neu, VEGF, COX-2, estrogen, and progesterone receptors on the survival in patients of high-grade neuroendocrine cervix. And only HER2/neu expression was associated with the prognosis, where it was seen that negative HER2/neu expression had shorter lifespan. Now the staging and imaging. The staging is done with the FIGO guidelines and the most recent is of 2018. Now, the Society of Gynecologic Oncology recommends, owing to the aggressiveness and of the disease, it recommends that CT or PET-CT should be done during the staging of the disease to stage it properly. Pelvic MRI is best when the tumor is more than 1 centimeter to look for the local extension and the relation with the adjoining organs. Now transrectal ultrasonography was found to be better than MRI in cases where the tumor size is less than 1 cc, and when we have to see for residual tumors after conization, and third, for when we have to look for parametrial infiltration. It is better than MRI. Now the prognosis. Even after multimodality treatment, it has been found that the prognosis of this cancer is very poor. And the most significant prognostic factor is stage of the disease. Other factors are age, lymph node metastasis, race, smoking at the time of diagnosis, pure small cell histology, and lymphovascular stromal invasion. The overall 5-year survival is of 36%, and the median survival is around 22 to 25 months. Is to be stage-wise, to stage-wise. In early stage 1 and 2, the 5-year overall survival is 31 to 51%, and in advanced stage, it is 0 to 7% respectively. Now the treatment. We first evaluate, do thorough physical and vaginal examination, and with imaging also, we assess whether the tumor is confined to cervix or it has a positive for distant mets. With MRI and ultrasound, we assess the size and parametrial involvement in early stage and locally advanced stage. And after staging, we categorize the patient according to early stage, locally advanced, and metastatic tumors. In early stage, we go ahead with, most of the cases, we go ahead with open radical hysterectomy with sentinel lymph node mapping and followed by chemoradiation or chemotherapy. Now, in locally advanced cases, the chemotherapy of choice is standard chemotherapy of choice is cisplatin and etoposide. When we have to go ahead with concurrent chemoradiation, it is suggested that chemotherapy 2 cycles should be given along with radiation, and the remaining 4 cycles should be given after the radiation. In metastatic diseases, we go for palliative chemotherapy. There is a study done by Wang et al. For in locally advanced stages, that is stage 2B and 4B, where they found that EP regimen, when it was given for 5 cycles, it was better, and the 5-year failure-free survival and cancer-specific survival was better. Further, they found that if it was combined with concurrent chemoradiation, then it further added and benefited the patient, and the failure-free survival and cancer-specific survival was better. Another study done by Zhuan P said that the adjuvant chemotherapy of at least 5 cycles of EP had improved 5-year recurrence-free survival. And they stated that for early stage, that is 1 and 2, concurrent chemoradiation had no effect, even in some patients having high risk factors, that is positive lymph node and positive parametrium. So there was yet another study by Ishikawa et al. That stated that radical surgery had a better overall survival than definitive radiotherapy. They further stated that the hazard ratio for patient not undergoing radical surgery was 4.74. They stated that response rates to EP regimen and irinotecan or platinum was better than taxane and platinum regimen. And atypical carcinoid significantly has less response rate than the high-grade neuroendocrine carcinomas. So with these studies, we conclude that the standard treatment of neuroendocrine cervical cancers, chemotherapy is for sure it is the standard therapy, but the radiation for early stage radiation and surgery, there are we have to we have to individualize the treatment according to the patient. Now we have we know that neuroendocrine cervical cancers are mostly in the young patients with a median age of 37 years. So fertility becomes a major issue. It can be done by 2 ways, by ovarian preservation and uterine preservation. When ovarian transposition is done, Even with that, after EBRT and IBRT, the egg retrieval was found only in 65% of the patients. And for in the when we go for uterine preservation, there are surgeries like abdominal radical trachelectomy and vaginal radical trachelectomy. And in these cases, even with assisted reproductive techniques, also the pregnancy rate was around 14.3 to 50%. It is recommended by NCCN guidelines that because of the micrometastases are more common and lymph node involvement is more common in neuroendocrine cervical tumors, so uterine preservation should not be done. Now, recurrences. The first recurrences are mostly extrapelvic sites, two extrapelvic sites, the most common being lung, 38%, liver, 34%, and carcinomatosis and brain involvement is seen in 25% of the cases. So we again evaluate the patient doing PET CT and or CT scan. We go ahead with molecular testing and we can go ahead with brain MRI. The most common regimen used in first recurrence cases is triple chemotherapy regimen. It is also known as Texas cocktail. It was evaluated in it was gynec oncology group study 240 also, and one more study was done on this. It constitutes topotecan, paclitaxel, and bevacizumab. So this study, Frumovitz et al. Was done to evaluate the effectiveness of triple regimen. They found that the median progression-free survival was better, 8 months versus 4 months with other regimens. And the median overall survival was also 9.7 months with the triplet regimen. This triple regimen is also beneficial because it is tolerated very well in the women who have undergone definitive chemoradiation. Now, for multiple recurrences, there are very few case reports that are there on the multiple recurrences on with neuroendocrine cervical tumors. So the biomarkers and the related therapy that can be used are in patients with PD-L1 positive, pembrolizumab and nivolumab has been used, where there is deficient MMR and MSI is high is there. We use pembrolizumab. Where we found that tumor mutational burden is high, pembrolizumab has been added. If there is a study where NTRK gene fusion positive patient was also mutation was also seen in one patient, and larotrectinib has been used. There's one study that has been done by Leonce et al. That evaluates the effectiveness of trametinib. It is a MEK inhibitor that is used in patients of recurrent cervical cancers, neuroendocrine cancers with KRAS mutation. The trametinib, when used with radiation, 3 cycles, there had been a complete radiological response. There was another study that evaluated PARP and PD-L1 as a potential therapeutic targets in high-grade neuroendocrine carcinomas. It was seen that MMR protein had intact expression in 100% of the samples. In PD-L1 expression, 8% was there in high grade and 50% was there in mixed carcinoma tumors. While PARP was there, expression was there in 91% of the cases, 55% having high expression, 36 having moderate expression. So there was another study done by Grande et al. Where pazopanib was evaluated in treatment of advanced neuroendocrine tumors. It was found to be effective, and to further for the selection of the patients, there was the cancer tumor cells and soluble VEGFR gene polymorphisms were included and tested, and if they were found positive, these patients were very good candidates for pazopanib. Now the surveillance. For neuroendocrine cervical tumors, there is 3-monthly surveillance done in the first 3 years and 6-monthly in the next 3 years. The SGO guidelines recommends that along with physical examination, there should be periodic full body imaging either with CT or PET-CT scan. To conclude my slide, neuroendocrine cervical cancers are rare form of cervical cancers with poor prognosis, even with multimodal treatment. In early stages, radical surgery with adjuvant or neoadjuvant chemotherapy is used. In locally advanced, concurrent chemoradiation and chemotherapy is appropriate. Despite aggressive treatment, because of the high chances of METs, the novel therapeutics such as immune checkpoint inhibitors and targeted agents should be incorporated in the treatment. Thank you.
Thank you, Pragati, for a very crisp presentation. The topic is open for discussion.
Yes.
If anybody has any questions, they can.
Is there any role of somatostatin receptor therapy or somatostatin receptor analogs which can be used in this?
Sir,
Like it is used in other neuroendocrine tumors?
Yes, sir. In other neuroendocrine tumors, there's role of somatostatin because they are mostly used in secreting neuroendocrine tumors. But
not necessarily only secreting tumors. It's based on the receptor state. It's based on the receptor status.
Yes, sir, to evaluate the receptor status also. But there is only one case report that I have gone through where dotatate scan was used and somatostatin receptor was used, and there was in proper the NCCN not neither.
Okay, fine. Just maybe I'm diverting from the topic, but tell me how can we use somatostatin receptors or this property of the tumor to our benefit in a clinical situation, in diagnosis as well as in treatment?
Sir, we can using the somatostatin receptors and the scans, we can diagnose at an early stage, and we can diagnose the METs at an early stage, and we can use somatostatin receptor analogs and for the treatment of these patients.
Like what?
Like octreotide.
Okay, so octreotide or somatostatin analogs is one. Any other way we can target these receptors?
Any other ways?
You have a case of a pancreatic NET which has also had a pelvic mass. What is she getting?
Sir, I've seen that she was getting chemo EP regimen along with octreotide.
No. She was getting octreotide with mTOR inhibitors. Monthly octreotide with the mTOR inhibitors. What's the role of mTOR inhibitors?
Sir, mTOR inhibitors Sir, mTOR inhibitors are tyrosine kinase inhibitors, which will inhibit which can be used in recurrences in or advanced neuroendocrine tumors.
mTOR inhibitors are not tyrosine kinase. mTOR inhibitors are mTOR inhibitors.
Yes.
Can anybody tell what is an mTOR inhibitor? What is mTOR? Naina, would you?
Sir, it is mTOR is mammalian TOR receptor, sir. It's different from tyrosine kinase receptor.
So what TOR stands for?
Sir,
Like
mammalian target of
rapamycin. Yes.
Rapamycin. The mammalian target of rapamycin is very much tyrosine kinase.
Sir, there is a in metastatic setup there is a option of lutetium-177 dotatate therapy, sir. If it is responsive to somatostatin analog, if the tumor, that's an option. But for highly advanced and in carcinoma setup where they are not responding to dotatate therapy, then lutetium therapy might not be effective.
Do we have any other questions for Pragati?
So Menag, when do you use this lutetium scan therapy? When do you use the lutetium scan? What is the ladder of neuroendocrine team?
Sir, neuroendocrine is like it can be well differentiated and poorly differentiated. When they are mostly in the GI setup, GEP NET, it has been tried in metastatic pancreatic setup, neuroendocrine, where lutetium therapy has been tried. If if it comes in the spectrum of carcinomas where they are poorly differentiated, in that case, lutetium therapy is not effective.
See, it's usually when it's the Ki67 1 to 2%, 2 to 10%, more than 10%.
Yes, sir. Yes, sir. It's based on that mitotic index. Yes.
That 2 to 10%, that too in setup of, mid-gut neuroendocrine, you can give this lutetium scan therapy. 1 to 2% you can give long-acting octreotide, and more than 10% you have to give chemotherapy. But if this can be extrapolated to cervix, we don't know. There are not many cases.
Yes.
We have anything else?